Thanks very much, Sammy. Welcome to you all. I'm so glad you could join this webinar. I'm Denise Doherty at AHRQ. I just wanted to provide a little bit of background on where these measures are coming from, who's supporting them. Next slide, please. So these, the Pediatric Quality Measures Program that these measures are a part of came from the Children's Health Insurance Program Reauthorization Act of 2009. There is now a new Children's Health Insurance Program Reauthorization Act, but this one came from the 2009 legislation that asked that measures be developed for pediatric quality of care. Next slide, please. So these are the 7 awardees, people and symposia who are developing measures, and you will see Dr. Rita Mangione-Smith's name in the middle of that list in the right-hand column. Next slide, please. So what makes this Pediatric Quality Measures Program under CHIPRA different? Well, the measures are explicit about the evidence base for their focus. They're developed with the input of patient and provider and Medicaid and CHIP program stakeholders, and they're able to measure disparities in quality for the most part. Next slide, please. The PQMP Centers of Excellence have accomplished a lot. There are 78 measures available, and we're still counting. There are 15 measure fact sheets available. There was one addition to the child course set that CMS recommends to Medicaid and CHIP programs for voluntary use. That was behavioral risk assessment and prenatal care. 3 of the measures actually have been endorsed by the National Quality Forum. One is the child age caps, which you won't hear about today, is one of the National Quality Forum Measure Applications Partnership top 3 recommended measures for Medicaid and CHIP voluntary use. As I said, there have been endorsements by the National Quality Forum, HEDIS, which is National Committee for Quality Assurance, and the National Quality Measures Clearinghouse. In addition, you can find on our website journal publications by the authors and information about e-measurement contributions. Next slide. These next couple of slides, which will be available to everybody in about a couple of weeks from this webinar, provide information about how to get access to these resources. Next slide. Next slide. So now I'm going to introduce the speakers. I'll introduce them all with a bit of bio information before they speak in order. So Dr. Rita Mangione-Smith is Professor in Chief of the Division of General Pediatrics at the University of Washington Department of Pediatrics, a senior investigator in the Center for Child Health, Behavior, and Development at the Seattle Children's Research Institute, and adjunct professor of health services at the University of Washington School of Public Health. She is director of the AHRQ CMS-funded Center of Excellence on Quality of Care Measures for Children with Complex Needs. She is also PI, principal investigator, on 2 multi-site studies focused on developing and testing quality measures for pediatric inpatient respiratory illness funded by NHLBI. That's part of NIH. And in 2009, she served as the co-chair for the AHRQ National Advisory Council Subcommittee on Children's Healthcare Quality Measures for Medicaid and CHIP programs. We are happy to have her today. Dr. Valerie Harder will follow Dr. Mangione-Smith. She's an assistant professor of pediatrics and psychiatry at the University of Vermont and directs the health services research team there for VCHIP, which is the Vermont Child Health Improvement Program. Her research focuses on the causes and correlates of children's health outcomes and measures the impact of quality improvement efforts in Vermont. She is lucky to have access and know how to use all payer claims data and medical records for interesting research projects and informative ones. Last but not least is Dr. David Bergman, who is an associate professor of pediatrics at Stanford University School of Medicine. He's been the past chairman of the American Academy of Pediatrics Committee on Quality Improvement and past chair of the board of the National Initiative for Child Health Quality. He's currently working on new models for the delivery of care for children with medical complexity and how these models interact with proposed payment reform. Dr. Bergman is the medical director for the Complex Primary Care Clinic at Lucille Packard Children's Hospital and is actively involved with patient care and teaching. So Rita, would you like to start?
Yes, thank you, Denise, and welcome to everybody attending the webinar. Thank you for your interest in the work that our center has been undertaking now for the last 4 years. So it's exciting to have the opportunity to share some of our best work with you. So I am speaking on behalf of the Center of Excellence on Quality of Care Measures for Children with Complex Needs, which was sponsored and continues to be sponsored by AHRQ and CMS. And this is a consortium of organizations working together under a common cause. We're based at Seattle Children's Research Institute, but you can see from this slide the many different institutions that have made huge contributions to what I'm about to present to you. Cincinnati Children's Hospital, Los Angeles, 2 different chapters of the American Academy of Pediatrics in Washington and Minnesota, 2 different Medicaid agencies, the Washington Medicaid Agency and the Minnesota Medicaid Agency, 2 high-powered research institutions, RAND and the Center for Effectiveness Research at Kaiser Permanente, and very importantly, our partners, Family Voices of Minnesota. I've entitled this talk Developing Measures for Children with Medical Complexity, and I'm going to be focusing on a set of measures that we developed called the Family Experiences with Coordination of Care, or FECC measure set. So I want to start out just so that we're all on the same page in terms of what our center means when we talk about children with medical complexity. So this is the definition that we settled on after reviewing many definitions of children with medical complexity. First of all, we consider these children to be those who have significant chronic conditions in 2 or more body systems. By significant chronic condition, we mean a physical, mental, or developmental condition expected to last at least a year that will use healthcare resources above the level for a healthy child, require treatment for control of the condition, and the condition can be expected to either episodically or continuously be debilitating for a child. By body systems, the body systems we include are mental health, neurological, cardiac, pulmonary, et cetera. You can see them listed there. So you're considered CMCs as if you fit into that definition. Or, alternatively, you can have one condition that we consider to be progressive, meaning that it's associated with deteriorating health with a decreased life expectancy in adulthood. So an example of that type of condition would be cystic fibrosis. Or you're a child who is technology dependent for at least 6 months. By technology dependent, we mean things like being ventilator dependent, being dependent on eating or nutrition, et cetera. Or you have a malignancy that has not been in remission for at least 5 years. So if you fit into any of those categories, our center considered that to be equivalent to being a child with medical complexity. So why is measuring quality of care for these children important? Well, really, there's very little known about the quality of care coordination being received by children with medical complexity. We know from national surveys that many parents will report not having had their needs for care coordination met, but that really doesn't tell us, for those where they are being met, what are the quality of those actual services being provided. So that's where we really found the gap. Care coordination, as many of you on the phone I'm sure know, requires substantial investment, resource investment. And research to date has really not demonstrated which aspects of care coordination benefit children with medical complexity the most. Most interventions that have been done have been focused on the frail elderly population, not on children. And the interventions that have been found to be effective in well-designed studies that were randomized and controlled really looked at bundled interventions where many things were being done. So the people in the intervention group, they did find better outcomes for those individuals, better utilization, lower costs, et cetera, better functional status or quality of life. However, we don't really know what in that bundle was driving those outcomes. So that's a limitation with the work that's been done to date looking at effectiveness of care coordination. Why is it important to peel those bundles apart and really look at individual processes of care that were included in those bundles to look at their relationship to outcomes? Basically because we really need to prioritize and incentivize care coordination in the context of limited resources. If we can't afford to do the whole bundle, we'd like to know which parts of that bundle are the most effective in terms of improving outcomes for these young children. So our main project aims were to develop and test quality measures for children with complex needs that incorporate assessments of the structure, processes, and outcomes of care. We really wanted our measures to be family-centered, and we wanted them to address care coordination across sectors. And the sectors we included were a child's medical home, which could be either a primary care site or a subspecialty site, hospitals, schools, child welfare, other services children might need like physical and occupational therapy services. So our approach as a center was to begin by looking at existing conceptual frameworks related to care coordination. We looked at the AHRQ Care Coordination Atlas. We did a lot of time studying conceptual frameworks that have been put forward by Rich Antonelli and colleagues. And looked at those different frameworks, looked at what our major goals were, and then developed our own framework based on those for care coordination and care fragmentation. So when coordination isn't working quite right. When we put that model together, what it allowed us to do was to really find sort of high-yield spots within the model where we were able to identify potentially important processes or structures of care that we felt would really drive effective care coordination. Once we identified those hot spots within the model, those ones that we thought would be high yield for looking at quality of care for care coordination, we then looked into the literature. And what we were trying to do was identify studies that had examined relationships between the various care coordination processes and structures that we were hypothesizing would be important and see how they related to child health outcomes. So we went through that process, and based on our conceptual framework and the literature reviews that we did, we developed a draft set of care coordination quality measures. Those quality measures were then put forward to a panel, a multi-stakeholder panel, where they did a process called the RAND-UCLA Modified Delphi Method. And our multi-stakeholder panel, much like Denise was alluding to in her earlier comments, included caregivers of children with medical complexity, Medicaid agency representatives, frontline providers, content experts, so people who are content experts in the care of children with medical complexity, and then also measurement experts. So we had a very diverse group evaluate the measures. They fell into three main topic areas: care coordination services, messaging, plans, and protocols. So the panel did their work. They endorsed 20 of the measures as being valid and important. And so those were the 20 measures that we moved forward in the process of measure development. And just in case you're curious, we started with 36 measures and we're down to 20 after the panel process. So we developed a 54-item Family Experiences with Coordination of Care, or FECC, survey to collect data for the 20 endorsed measures. So this particular survey, after we developed it, was informed by an additional 2 rounds of what we call cognitive interviewing, where we went to both English speakers and Spanish-speaking caregivers of children with medical complexity and kind of did think alouds with them when they read a survey item, does this item, what does this item mean to you? And that really helped us to refine the item so that we knew that parents were understanding what we were trying to get at with the question items. And an interesting thing we found through this process was that the parents who we interviewed did not understand the term care coordination. It didn't matter how much definition we put around it. It was still very difficult to get people to understand that. So within the Family Experiences with Coordination of Care survey, we never used the words care coordination, which was kind of an eye-opening experience for all of us involved in this development process, but an important finding. So then once we developed and refined the survey, we field tested it in 2 states by telephone and mail administration between August and November of 2013. So caregivers who are eligible to be in the field test were primarily parents of children with medical complexity. They had to have at least one child who was complex. That child had to be between 2 months and 17 years of age, insured by Medicaid in Washington or Minnesota, have been continuously enrolled just for the last 2 months of 2012, and had to have had at least 4 visits to outpatient providers between August of 2012 and July of 2013, just prior to our survey start date. The reason for the 4 outpatient visits was we really wanted a group of parents whose children were relatively high utilizers of health care, with the idea in mind that these would be children who would be more likely to need care coordination. So we identified 1,500 families in 2 states, Minnesota and Washington, with at least one child with medical complexity. To do this identification, we utilized the pediatric medical complexity algorithm. This was another one of our center's assignments earlier on in our work, was to develop a methodology for categorizing children by medical complexity, and that's what the PMCA, or Pediatric Medical Complexity Algorithm, does. So it was developed collaboratively between investigators at Seattle Children's Research Institute and Washington Medicaid. It was based on the Chronic Disability Payment System, or CDPS. We did a lot of adaptation to that system to come up with PMCA. It can be applied to Medicaid administrative claims data. It can also be applied to hospital discharge data and to electronic health record ICD-9 coding data. It identifies 3 groups with high sensitivity for the complex chronic condition group and high sensitivity for those without chronic conditions. It performs less well on the non-complex chronic condition group, but those are the 3 groups that it identifies, and it's a very good group, a very good grouper for identifying children with medical complexity, which was our main goal. So among the 3,000 caregivers of children with medical complexity that we sampled, you can see when we contacted them for surveying, either by phone or mail, this is how the sample ended up being distributed. And so we ended up with 1,191 respondents, or a 40% response rate, and those nicely split out about half from Washington State and half from Minnesota. So now I'm going to go into some of our field test sample characteristics so you can understand who the children were that were included in this field test. So we did have a good range of ages, with the most common age being between 6 and 10 years old. Race ethnicity was a reasonably diverse population. However, African Americans were underrepresented compared to nationally. But we had 25% Hispanics. The largest group was white non-Hispanic. Slightly under half of our sample fell into that category. And the other category is primarily mixed race. For survey language, 87% of our sample completed their survey in English, and 13% completed it in Spanish. And here, this was sort of a check for us. We wanted to, once we had our sample, look into their Medicaid claims to see the number of providers these children had seen greater than or equal to 1 time in the last 12 months. And you can see we were successful in getting high utilizers who were tending to see multiple providers. Most of our sample had seen at least 3 providers, and 35% had seen 6 providers greater than or equal to 1 time in the last year. So definitely children with lots of utilization and medical issues. Now I'm going to move on to our field test results. So our survey measure collects the measures from 3 different topic areas, like I mentioned earlier. Care coordination services, there are 8 measures that are collected for that particular topic area. There are 9 measures on messaging, and there are 3 that address protocols and plans for these children. The survey for the field test purposes included validation measures. We included the clinician group's Consumer Assessment of Healthcare Providers and Systems, or CGCAP's Access Composite, and then the CGCAP's Global Provider Rating. We also included 2 care coordination outcome measures that were adapted from the adult CAP's health plan supplemental items. And I'll go into more detail on those validation items. But I should point out that those measures were only included in this field test version of the survey. As the survey exists today, when we distribute it to people who are interested in using it, those measures have been stripped out, and it only includes the actual FECC measures. So the FECC quality measures are scored in 2 different ways. There's 2 different types of measures that are scored. There are binary measures, which are just yes or no, did you receive indicated care, or did you have an indicated structure of care in place? And then there are multi-component measures where the measure, you have to satisfy several different components to get your final score on the measure. And for those measures, we use something called linear mean scoring. And again, I'm going to go over this in a little bit more detail so that it makes sense to everybody. So I apologize for the small print on this, but I will read it for you. This will give you a sense for how we went from a draft quality measure statement to survey items, and then how we score those survey items to actually score the measure. So one of our measures was caregivers of children with complex needs should report that their child has a designated care coordinator, so a structure of care measure. So that was operationalized into the following survey item. Your child's main provider is the doctor, physician assistant, nurse, or other healthcare provider who knows the most about your child's health and who is in charge of your child's care overall. The questions in this survey will refer to this provider as the main provider. Please think of that person as you answer the questions. So, getting help to manage your child's care. These first questions are about the people in the main provider's office who may help you manage care, treatment, and services for your child. In the last 12 months, did your child visit more than one doctor's office or use more than one kind of health care service? Now, parents had to answer yes to that question to be in the eligible population for this measure, or the denominator for this measure. If they answered no, they were not included in this measure, because our assumption here is if you didn't need services from more than one person or one service, you didn't probably need care coordination. So if they answered yes, then we go on to the scoring part of the measure, which is, did anyone in the main provider's office help you to manage your child's care or treatment from these different doctors or providers, yes or no? Yes, you pass the measure, no, you don't. So this is one of the binary scoring examples. So at the individual child level, scoring is 0 or 1. At the population level, if you were to aggregate scores across several children, it would be the percent of eligible individuals scoring 1 on the measure. Now, for the multi-component measures, or linear mean scoring, here's an example of how that works. So caregivers of children with medical complexity should report receiving a written visit summary following all outpatient visits in the last 6 months, or report access to a patient portal that provides a visit summary, and it should contain the following elements: current problem list, medication list, drug allergies, specialists involved in the child's care plan follow-up, and what to do for problems related to the outpatient visit. So how does linear mean scoring work? Here's how that particular measure was converted into survey items. So we start with saying a written visit summary sums up what happened during your child's visit to a healthcare provider. A written visit summary can be available on paper, on a website, through an app, or sent by email. In the last 12 months, did anyone in the main provider's office give you a written visit summary after your child's visit? You had to answer yes to that question to be in the eligible population for this particular measure. If you answered no, you were not included in this measure. So then scoring is question 18. How often did the written visit summaries you got from the main provider's office include? And then it lists all the things that I just went over on the measure. And the parent could answer never, sometimes, or always. So to score this measure, what we do at the individual level is we calculate the score by taking the average of the non-missing items. So in this particular case, the parent skipped item D, so that particular item is not included in the scoring. Only the items that were answered are included in the scoring. So if you answered always, you get 100. If you answer sometimes, you get 50. If you answer never, you get a 0. And you can see down at the bottom how they are summed together, right? And we divide by 6, not by 7, because this item was skipped. And we get the score for that individual child on this measure out of a 0 to 100 scale is 66.7. To get a population score, you average the individual scores for each child in that population to get the overall average score. So I'm going to tell you which measures we're looking at and whether they were binary or multi-components, and you should now understand kind of what that scoring means. So again, these are the percent of eligible individuals passing the quality measure in the population. So when we asked, does your child have a care coordinator, 72% of eligible caregivers endorsed that their child had a care coordinator. Did they know how to access that care coordinator? A large majority said yes, so 96% passed that measure. Did the care coordinator help to obtain community services? Only 50% responded affirmatively to that. Had the care coordinator initiated contact with them in the last 3 months without the parent having to initiate contact first? Only 45% passed that measure. And did the care coordinator ask about progress towards goals in the care plan? Now you see the eligible population on this one gets pretty small because not only do they have to have a care coordinator, but they also have to have endorsed having a care plan, which is another one of our measures we'll come to in a little bit. So you were only eligible if you had both a care coordinator and a care plan. So we get a much smaller eligible population, and 85% of those who are eligible answered yes. The next measure, did the care coordinator assist with specialty services, referrals, and appointments? 73% of caregivers endorsed that had happened. Now, looking at our multi-component measures for care coordination services, we asked, did the care coordinator ask about concerns and health changes? And the score on a 0 to 100 scale was 81 with a standard deviation of 26. And when we asked, was the care coordinator knowledgeable, supportive, and did they advocate for the child's needs? So again, you can see these are multi-component measures, and on the 0 to 100 scale, the average score in this population was 84. Now for our messaging measures, these are the binary ones. When a child was hospitalized, so again, you'll see the eligible population is smaller because we only ask these questions of children who were hospitalized in the last 6 months. Was the caregiver invited to join hospital rounds? And 51% of caregivers endorsed that had occurred and passed that measure. Caregivers, did they have access to an electronic health record? Only 36% of parents reported that was the case. And for children who were school-aged in the sample, had their main health care provider communicated with the school staff about the child's conditions and needs, special needs, of the parents who were had an eligible child who was school-aged, only 28% endorsed that kind of contact had occurred in the last 12 months. Here are some multi-component measures for messaging. Was there appropriate after-visit summary content on a 0 to 100 scale? That was the example I showed you earlier. So the overall population score on this was 81. Was the written visit summary useful and easy to understand? It had a score of 86. For hospital summaries, was the content appropriate? 89. Was it easy to understand? A score of 92. For electronic health records, for those who had access to one, did they include immunization and medication information? That had a score of 70 on the 0 to 100 scale. And does the caregiver who needs access to medical interpretation at all of their visits actually have that access? And the score there was 83 on a 0 to 100 scale. For plans and protocols, there are only 3 measures in this topic area, and they were binary. So they, again, represent the percent of eligible individuals passing the quality measure. So did the child have a shared care plan? This is a shortened version of the measure, but it's basically a care plan where the parent and the main provider worked collaboratively to form the plan. And 44% of parents endorsed that their child had a care plan that they had taken part in developing. For children who were 15 years of age or older, we asked, was there a written transition to adult care plan that had been developed? That was only true for 10% of them. And for children, all children in the sample, we asked if the parent had taken part in helping to develop an emergency care plan that they could take to ED visits or urgent care with them, and only 20% endorsed that had occurred in the last 12 months. So those are the scores on the measures, and now I'd like to spend some time talking about the validation of the FECC measures. I mentioned earlier that the evidence base was very sparse, in fact non-existent for children with medical complexity. So we really felt it was important that we take some measures that have previously been validated and see how our measures correlated with those. So we hypothesized that better scores on the FECC measure set measures would correlate with higher scores on these existing validated measures. So in the survey, like I mentioned before, we collected the CHIPRA measures. So we collected the access composite, which is answered on a scale of always to never, and it asks about getting appointments as soon as you needed them for urgent or routine care, having questions that you phoned in answered on the same day you made the telephone call, and when you were there to see a provider, did you see the provider within 15 minutes of your appointment time? There was also the global CHIPRA measure that we collected, which asked their rating of their main healthcare provider on a 0 to 10 scale, which gets converted to a 0 to 100 scale for analysis purposes. Where 0 is the worst possible provider and 10 is the best possible provider. The access composite is also scored on a 0 to 100 scale. I also mentioned that we adapted some care coordination outcome measures from the CAPS health plan supplemental items, and the two that we adapted were as follows. So overall, how often did the main provider's office give you the help you needed to manage your child's care or treatment from different doctors or care providers in the last 12 months? Always to never. And then overall, how satisfied or dissatisfied were you with the help from the main provider's office to manage your child's care or treatment in the last 12 months? And that went from very satisfied to very dissatisfied. And these measures also were converted based on those scales to a 0 to 100 scale. So when we did our validation analyses, we adjusted for important case mix adjusters that have been established for these particular measures. Plus, we added in which state they were in, Minnesota or Washington, how they responded to the survey by mail or phone, and what language they did the survey in, Spanish or English. And you can see the demographics that we adjusted for there. So our adjusted analyses, we computed what are called Pearson correlations between our FECC quality measures and the validation measures, so the CHIPRA and the care coordination outcome measures. The correlations could go anywhere from -1 to +1. We considered a correlation significantly related if the p-value was 0.05 or less. And we, in the following slides, if you see a result that's in red, it means there was a significant but small correlation, so correlated at a 0.05 to 0.2 level, with 1 being the highest correlation. If it's a blue result, it's a significant medium correlation, so between 0.2 and 0.4. Okay, so this is a very busy slide, so let me orient you to it. Down this column are the measures that we just went over, where I told you the scores of the measure. The header of this column is the CHIPRA access composite, so that's on a 0 to 100 scale, and as you know, we converted all of these measures to a 0 to 100 scale. And then the CHIPRA main provider rating, which also went from 0 to 100. And what we were happy to see was that pretty much, with the exception of they're asked about progress towards goals, all of these measures were correlated with the existing previously validated CG-CAPS measures, in some cases at very highly significant levels and with nice medium-sized effect sizes for many of them, or correlations for many of them. We also, what I've also put here are called the beta coefficients, and what those tell you is that if you were to go from a 0 on having a designated care coordinator to a 1, which means your score goes from 0 to 100, your increase in your CG-CAPS access score would go, your score would increase by 7. Your CG-CAPS provider rating would increase on the 0 to 100 scale by 6 points. So here you can see some pretty big increases in what your CAPS scores would look like if you went from having a score of 0 on these FECC measures to having a score of 100. Similarly, these are the messaging quality measures, and we see many of them were correlated with the CG-CAPS access and provider rating, with the exception of being invited to hospital rounds, which kind of makes sense because CG-CAPS is really asking about outpatient care, so one might hypothesize that those would not be related to each other. And the only other ones, again, having a hospital summary that was easy to understand was not correlated with access. Okay. And then these are the plans and protocol quality measures, and again, we see, with the exception of the main provider rating and having a physician care plan, all of the others were correlated with the CG-CAPS measures. And here we suspect we're getting into statistical power problems because, as you'll recall, very few parents endorsed having a transition care plan. I believe it was only 18 parents in our sample. So now we're looking at the same sets of measures, again, the care coordination services measures, but now we're looking at them in relation to those care coordination outcome measures. So this is the parent saying that the main provider's office helped them with needed care coordination. And this is the one looking at were they satisfied with the care coordination that they got. So if you look at our care coordination services measures, most of them have a medium-sized correlation with these two outcome measures, which was really good to see. And you can see, again, if you go from 0 to 100 on one of these measures, you get a really substantial bump in the score that you would get on the CAPS measures, 32 points in the case of getting needed help and 22 points in the case of satisfaction with that help. And then for the messaging ones, we see a similar pattern. One thing I should back up to show you, these were not applicable to having a designated care coordinator because we didn't even ask you these survey outcomes unless you had endorsed having a care coordinator. And in this case, we were not able to ask, we were not able to look at the relationship between having access to needed interpreter services and these two outcomes, again, because our sample sizes were so small. And then finally, plans and protocols. We see that in the case of having a shared care plan that the main provider developed with the parent, that was significantly correlated with a parent reporting they had received needed care coordination assistance, as well as the emergency care plan, but not for the transition care plan. And again, we may be running into sample size issues with the transition care plans. So to summarize the findings I've just gone over, most of the adjusted correlations between the FECC measures and the CG-CAPS access and global provider measures were statistically significant at a p less than 0.05 level. So for the care coordination services measures, 15 of the 16 correlations were significant, 5 in the medium range. For messaging, 14 of the 18 were significant, again, 5 in the medium range of correlation. And for plans and protocols, 5 of 6 were significant with 2 in the medium range. Now, again, most adjusted correlations between the FECC quality measures and the care coordination outcome measures were also statistically significant at a p less than 0.05 level. For care coordination services, 13 of 14 were significant, 11 were in the medium range. For messaging, 11 of 16 of the correlations were significant with 5 in the medium range. And for plans and protocols, 2 of the 6 were significant with 1 in the medium range. In terms of our FECC quality measures, significantly correlated with all validation measures. The reason I'm going over this list for you is one of the questions I always get is, if you were going to pick, like, you know, the best measures in the set, what would they be? To me, they're the ones that perform the best in the validation analysis, and so that includes 68 FECC care coordination services quality measures, having a designated care coordinator, knowing how to access that person, having that person help you get needed community services, having that person routinely ask about caregivers' concerns and health changes, having them assist with subspecialty appointments, and having them be knowledgeable, supportive, and advocating for the child's needs. For the messaging quality measures, the ones that kept bubbling to the top, 4 of 9 of them seem to be very strongly correlated with all the validation measures. Caregiver access to the EHR, provider communicates with the school about the child's special needs at least once a year, after-visit summary content is helpful and easy to understand, and hospital summary content is easy to understand. And then in terms of there are also some measures that were significantly correlated with all of the measures except for satisfaction with care coordination, and those were 2 of the 3 plans and protocol measures. The measure related to having a shared care plan that had been developed with your main care provider for your child, and having an emergency care plan. So those are the main results. We also did a sub-analysis where we wanted to examine disparities. We looked at performance on the measures by racial ethnic group, and I'm happy to report that we did not see any differences in scores on the measures by racial ethnic group. However, we did see some differences by English language proficiency. So this slide kind of summarizes those findings. On this left-hand side of the graphic, you again see some selected measures from the care coordination services, messaging, and plans and protocols. Interestingly, what you'll see, and LEP stands for low English proficiency. Families of children with low English proficiency actually scored better in terms of reporting that they had a care coordinator and getting help with access to services from that care coordinator, so community services and specialty referrals. However, they scored less well on knowing how to access their care coordinator. They scored less well on having care coordinators actually ask them about their concerns and health changes in their child, and less well on reporting that they felt their care coordinator was knowledgeable, supportive, and advocated for their child's needs. In terms of messaging, they were more likely to report that the main provider staff had communicated with their child's school. They were less likely to report having appropriate visit summary content, and they were much less likely, almost less than half as likely, to report having access to an electronic health record for their child. Plans and protocols, they were actually more likely to endorse having a shared care plan or an emergency care plan for their child. And then we looked at our outcome measures, those care coordination outcome measures that were adapted from CAPS, and they were less likely to report having received all needed help that they needed with care coordination. So in summary, for these findings, we did see some disparities exist in receipt of needed help with care coordination for low English proficiency caregivers. The LEP was positively associated with having a care coordinator and receiving help with access-related aspects of care, but was negatively associated with communication-related care coordinator attributes and reporting that their needs for care coordination had been met. So what can we conclude from all of this? The FECC measures enable evaluation of care coordination quality by caregivers of children with medical complexity. This is the first set of quality measures specifically developed to assess care provided to children with medical complexity. We were able to detect variation in quality of care coordination being provided to these children. And we were able to demonstrate convergent validity with established measures of caregiver experience, including the CG-CAPS and adapted CAPS health plan care coordination outcome measures. We feel that these are measures that are useful for identifying disparities by caregiver English proficiency. They can be used to assess quality of care coordination over time at the state, health system, or health plan level, and they're currently publicly available for use. What were our challenges in doing this work? I've mentioned a couple of times the sparse evidence base supporting these measures, so I really feel like for due diligence we need to continue to, as people collect these measures, really try to understand even more than we already have their relationship to better outcomes for children with medical complexity. We really can't apply these at the practice level in many cases because there are too few children with medical complexity in any given practice. For some practices that may be different if this is the main focus of the practice, but for most primary care practices, it really would not be possible to use these for practice level improvement because of sample size issues. A practice would need to have more children to adequately apply these at that level. They don't really apply to children with non-complex chronic disease. However, one thing that our center is really focused on is trying to understand, looking at the combination of non-complex medical disease and social complexity. For example, having a parent with a mental health condition or substance abuse problem or being severely poor, how does that interact with having one non-complex chronic disease like ADHD or asthma, and might those children also need care coordination? That's some of the other work that we're still actively working on. And then survey data collection is expensive, but I will tell you in this field test, we had a companion set of measures that matched 10 of the survey-based measures that we attempted to collect both in electronic health records for a subsample of the survey population and in some cases still paper medical records depending on the child's main provider's practice. And we really are not able to find the information to score these measures in medical records, either paper or electronic as they exist today. So parents really are the only source of information for many of these measures. So who's using the measures and how can you access them? You're going to be hearing from one of the users, or two of the users briefly in a moment. There are two Center for Medicare and Medicaid Innovations grantees, the Round 2 Healthcare Innovations Awardees, or HICIA as some people know them, the Children's Health Association HICIA grant recipients, and also the grant recipients here at Seattle Children's are using the FECC measures to evaluate their programs. And then the Vermont Child Health Improvement Program, you'll be hearing from Valerie Harder momentarily about that. And then there's a PCORI grantee who I am collaborating with where we're assessing quality of care coordination for children with disabilities using the FECC measures. And then for those of you who are interested, the measures and specifications for eligible population and scoring are available by, at this point in time, emailing me. But that our future plans are to, you can see the third bullet point, we're developing a local website here at Seattle Children's Research Institute, and we'll be posting all of our COE for CCN measures, including detailed measure specifications, data collection tools, and programming code in some cases. Our future plans for the center are to apply for NQF endorsement for a subset of the measures I just went over. Very likely those last 12 will be among the top candidates that we'll consider because they have the strongest measurement properties. We will also be applying to have all of the FECC measures posted on the AHRQ National Quality Measures Clearinghouse website. And with that, I'm going to turn it over to Valerie Harder.
Thank you, Dr. Mangione-Smith. I'm Valerie Harder. I'm assistant professor at the Vermont Child Health Improvement Program at the University of Vermont. And approximately a year ago, we began a practice-based care coordination quality improvement learning collaborative with 9 different pediatric practices who had embedded care coordinators. And the quality improvement learning collaborative was focused on children with special health care needs. So since, we've had 4 in-person learning sessions and monthly all-practice calls to work on quality improvement PDSA cycles with these practices. And in addition to improving the care coordination at the practices, one of our aims was to improve family experience of care coordination. And that's when I heard about Dr. Mangione-Smith work on developing this questionnaire, this assessment. So we contacted her, and she was willing to share her family experience with coordination of care measure set before she even went through her analyses, which was wonderful for us. We did not use the whole measure set, but we focused on questions related to access of care, access to the care coordinators, and I'll present some of our results for those measures, and the questions related to the shared care plans. So far, we've collected 49 baseline assessments of the family experience with coordination of care, and our goal is to reach 225 with our practices. Right now, we've had reassessments following up after 6 months with, it says 4 here, but we've recently received 5 more, so now we have 9. So for the results, I'm just showing some of the questions that link well with the slides that you've just seen from Rita. So for our sample, we asked them whether or not they had a care coordinator. And in our sample, 72% said yes, they do have a care coordinator. And this is compared to what you saw on a previous slide of 71% from the English-speaking group that Rita's research looked at. So amongst that 72%, 100% of our sample said they could access their care coordinator. And of the 72%, 85% said that their care coordinator always helped them to manage care. So we're getting some positive results from our assessment, and it's nice to see that it lines up well with the Seattle group's work. In terms of the shared plans of care, we have 35% of our samples saying they had a shared plan of care. And from the previous slide that you saw, I believe it said 41%. So again, it looks like we're matching up with Rita's data. Amongst that 35%, we have 69% who have a copy of their shared plan of care. And amongst the 35%, 81% said their care coordinator talked about progress towards goals. So we have some other follow-up questions, and our main goal is to continue to collect reassessments, and we hope to have a large enough sample to show an improvement in family experience with coordination of care at the end of our study. And we're continuing on for 2 more years, and we're recruiting more practices at this point. So we're very excited to keep going. So I wanted to stop there, and I can hand it off to Dr. David Bergman to talk about his work.
Well, good morning or good afternoon. What I'd like to share with you today is one of the Healthcare Innovation Awardees to the Children's Hospital Association, a little bit about why we chose the FECC instrument and how we hope to be using it. What we've done in our application to the CMMI Healthcare Innovation Award was to really put in a kind of 2-pronged program, one where we're going to be looking at care model transformation with a big emphasis on care coordination, and the other piece was payment reform. So we're really working with 10 major children's hospitals across the country. We will be recruiting over 9,000 children and families, and in addition, we're currently negotiating with 7 states to have the Medicaid claims data and also to look at models of payment reform. Needless to say, it's a large project, and we looked at a number of outcomes. And one key of these was patient experience. But in addition, we were looking at cost and utilization, another family-centered variable, family burden, medical home index, and provider experience. Ultimately, we really felt it was important to correlate changes that we had in process in terms of adoption of the model with changes in outcomes, including both cost and utilization and patient-centered outcomes. Our grant had a large research group that goes along with it, and we debated a great deal looking at the patient experience measures. And I was fortunate to hear about Rita's work. And what our research group found particularly attractive is that, one, this was a well-thought-out study that basically had its origins in the qualitative work with families that we were targeting, was evidence-based where possible, and what was most important, that it was validated in children with medical complexity. So we really felt that this was certainly best of breed measure that we were going to get with patient experience. We are only using the patient coordination part of it, and the reason for that is because we're trying to limit the burden on families and not take too much of their time in filling out all these patient surveys. I wish I had data to share with you. We will be going in the field with our first round of surveys in about a month, and I'm hopeful in the next several months at least we'll have some baseline data on how the FECC performs in our target group. And with that, I'll pass it back to Denise Doherty.
Thank you very much, David, and thank you, Valerie and Rita. We are now going to turn to some questions and answers, hopefully. So you can, if you want to raise your hand, you can get in the queue for asking questions orally. You can also type in questions in where you see the Q&A section. And we will let's take the first several, which were typed in as folks were talking. So the first three actually cover the same kind of question, I think. So the first one, relating to slides 19 or 20. So if not care coordination, how did you describe and define the set of activities? The next question, how was care coordination defined to the families? Many families have a care coordinator but don't label them as such, or some teams have multiple people doing care coordination. And the third related one, you mentioned that parents did not know the term care coordination. What term/language did you use? How did you refer to the care coordinator? And what term did you use? Did parents understand it? So I think that's a question for Rita.
Yes. So hopefully when I gave you a couple of the examples of how we operationalized the measures into actual survey items, that might have gone some way, some distance in explaining how we did that. We talked about the person who helped you to manage your child's care with different providers and different healthcare services. When the parent, that's how we asked, is there anybody in the main provider's office who helped you to manage your child's care with these different providers and different healthcare services? And if they answered yes to that, we then gave them a list of different options for who that person might be. It could be their main provider, it could be a social worker, it could be a nurse, it could be a front office staff person, it could be what's labeled as a case manager or a care coordinator. People selected all different, so they could also select more than, more than one person was helping them. So we do have that data, and we counted any of those as satisfying that measure, as long as the parent had indicated that there was somebody in the main provider's office who was helping them to manage their care with different providers and services. And that is the language we used throughout the survey, the person who helped you to manage. It sounds very clunky, but in our cognitive interviewing, that's really what we learned we needed to do for people to understand what we were asking.
Okay, thank you, Rita. So now we have another question. To clarify, are the items about the hospitalization summary still anchored to the main provider, or are they anchored to the hospital's discharge staff?
So those are anchored to the hospital discharge staff.
Okay. Next question is, the wording in the survey seems to imply that a care coordinator is housed within the medical home of the patient. Can the tool be used if a care coordinator is based in the field but not in the medical home itself?
That's an excellent question, and in fact, in the Seattle HICIA grant, the CMMI grant here, our model of care that we're testing is to have regional case managers for SSI children here in the state of Washington. They are not practice-based, and I do have a version of the questions that takes the main provider's office piece out of it. Everything else is the same. So we really just did some wording changes, and if there are people who are interested in that kind of wording, that version of the survey exists, and I'd be happy to share it.
Great, thank you. So the next question is, I think, again for Rita, though others may have different approaches. It looked like all the questions in the multi-component measures were weighted equally. Are there any plans to weight these based on input from families or other considerations?
You are absolutely right. They are weighted equally, and at this point in time, we do not plan to look at weighting them differently. The way we kind of dealt with that is the decision to not count missed items in our scoring. That was something we took to our multi-stakeholder group here within the center. We considered many different ways of scoring those particular measures. The most stringent being you had to give zeros for ones that were missed. To what we ended up with, which was the linear mean scoring of the non-missing items. But in terms of weighting, we really felt at this point in time that would be quite subjective, and didn't really feel like there was a good objective way to implement weighting of those items.
Thank you. So the next question is for Dr. Harder. Did you use the same definition as used by the Seattle team of a child with medical complexity for purposes of your learning collaborative?
No, we used the phrase children with special health care needs, and we allowed the providers to identify those children in consultation with some of our lead medical professionals on the learning collaborative.
Great, thank you. The next question is, are these results published in a consensus article for future reference? And I know Rita is in the midst of getting her results published.
Yes, that's
Rita,
correct.
do you want to address that?
Yes, we actually have 3 publications from the data I presented today that are in process, and we're hoping will be available for public use within the next 12 months. And the website I told you we were working on at Seattle Children's Research Institute, once those publications are available, we will provide links to them.
Thank you. And the next question. I am from a large hospice organization working with pediatric hospice and palliative care patients. Has there been any thought to include programs such as this in the use of this survey? Many of the outcomes align well with our specific program outcomes.
I actually think that would be a great use of these measures, because I think many of the measures apply very strongly to that population. So yes, I would strongly endorse using them in that population.
Great. Okay. The next question is, what's the minimum number of surveys that need to be completed in order to achieve significance? You mentioned that this tool would be difficult to use at the practice level.
Yeah, so the minimum number that we arrived at in doing, looking at reliability for getting reliable scoring would be 200, a sample of 200 surveys.
Okay, great, thank you. Another question, a minority of patients have care plans. For the 20% who have them, who generates them? Is there a national standard template for a care plan that you recommend? And everybody might want to comment on this one.
Comment on that. To my knowledge, there is no national standard, but there are active efforts going on to create a national standard within EHRs. I think that's still a work in progress. And the care plans that parents had when we did focus groups around this came in all different varieties, and they were usually put together either mainly with the provider who the parent considered their child's main provider, and that was not necessarily a primary care medical home. And in fact, in most cases, it tended to be a subspecialty medical home or a medical home based in a clinic for children with medical complexity. Those were the most common sources of those care plans that we came across in our field test, but I'll let Valerie and David respond to that also.
Sure, this is Valerie. In In our Learning Collaborative, we have guided our practices to look at the Lucille Packard Foundation's guidelines for best practices and the components which are good to include in the shared care plan. So they're clearly laid out there. They don't give an example that says this is exactly how the shared plan of care should look, but these are the components that should be included. And I think it's a wonderful guide, and it's available on their website.
This is David Bergman. I will just echo what Rita said. We had 10 different programs, and we've involved over 30 practices, and we've seen just innumerable versions of care plans. And what we're actually focusing on is what are the core elements in those care plans that need to be documented rather than trying to promulgate a specific template.
Okay, thank you. Thanks, everybody. I have a question from one of your state partners, Rita, saying, I am from Minnesota, just curious as to where the survey was tested in Minnesota.
So the sample was drawn from the All-State Medicaid database for the year of interest. So it was enrollees from 2012. So it really included children from across the state. It was not limited to any given geographical area because the sample was selected, starting with the whole state population, applying the pediatric medical complexity algorithm to identify the 6% of children who were insured for at least 2 months during the year in 2012 who were in the complex chronic condition group, and then we further narrowed it to those who had had at least 4 visits. So that's how the sample, and they had to be between 2 months of age and 17 years of age. So that's how the sample was selected. It was not a practice-based selection or a geographical-based selection.
Thank you. So we have a question from, a couple of questions. One, how does one obtain the PMCA, Pediatric Measure, now I've forgotten what it means.
Medical complexity algorithm.
Medical complexity algorithm, okay.
Email me.
Okay.
And it will be posted on our website, we're hoping by the end of this month. So it won't just be emailing me all the time. I can send people to the website to look at all of the available tools.
Okay, thank you. We also have the journal article associated with it on the AHRQ website. So somebody on the phone has a question. Joanne Cox, do you want to ask your question?
Hi, we were wondering about operationalizing the connection between parental, mental, and physical complexity with the child's diagnosis. I was wondering if there have been any attempts to use payers to link that on a statewide or on a system-wide level.
That's a great question. So one of the other measure development assignments that our center received in this effort was to try to develop a way to identify children with social complexity risk factors using Medicaid administrative data. We have done that work. We'll be publishing that work hopefully again within the next 6 to 12 months. And it's basically what we came up with was a list of 9 key factors. Within Washington Medicaid, they have an integrated database where we were able to link children with their caregivers, with their biological caregivers, and then through various data streams that they had at Washington State, we were able to collect information about a pretty rich series of social risk factors. And the study that we did in relation to that is we used the pediatric medical complexity algorithm to first classify children by level of medical complexity. And then we looked at the presence or absence of additional social risk factors and how those related to emergency department utilization and adherence to the American Academy of Pediatrics Well Child Care visit schedule for children 5 and under in the sample. And we found it had very interesting and compelling results showing that even after a controlling for the presence of medical complexity, so independent of whether or not you had medical complexity, as your number of social risk factors increased, your ED utilization went up, your well child care visit adherence went down, which to us was, we were using those as a proxy for potential need for care coordination because, you know, poor patterns of utilization sometimes call out the need for care coordination. So that's work we also will be publishing and posting on our website when it's available, and I'm happy to share that list of risk factors and how they were operationalized, at least within the state of Washington.
Okay, thanks, Rita. Next one, looking at the screen now, are the FECC measures meant to be used in a whole set, or can they be used apart in 3 separate sets? And can they be used more distinctly and individually with questions as long as eligibility is set?
Yes, so that is an excellent question. Thank you for asking. You can tell from what Valerie said and from what David said, and what I'll also tell you about our HICIA grant. You can pick and choose any of those 20 measures. They are not composites. Even the measured topic areas I was using, that was really just to organize things for presentation. They are not sets that you need to use or even subsets that you need to use. They are meant to be 20 individual measures, and you can, like I said, really pick and choose which ones you really think are relevant for your population. So if you're already doing a caregiver survey and you don't want to add 54 more items, you can really just pick the measures that you want, look at our data specifications to figure out which items you need to ask to get at eligibility and scoring, and then just include those items in your survey.
Great, thank you. Another question on the screen, were there differences in responses from different ethnic/cultural groups?
Yes, there were. So we had equivalent response rates for the phone. We had much lower response rates in the low English proficiency group and the parents with lower levels of education on the mailed survey group, which is very consistent with previous survey research. So was not a great finding, but not a surprising finding that we got better responses from those particular groups when they were interviewed by the phone.
Okay, thank you. And Valerie or David, I know, David, you don't have any responses yet, but you might want to, Valerie first.
Sure. Well, up in Vermont, we don't have a lot of racial diversity, so it's not something we can look at in our study.
This is David. It is a problem. We're actually going to be using email, and folks that don't respond to email will be doing phone follow-up.
And you have a large Hispanic population, you say?
We do. We about 35–40% are Hispanic.
Thank you. Now to someone on the phone. This is for Rita. How would use of the survey for children who don't necessarily meet the CMC criteria affect the results, interpretation, and comparisons across populations?
So if you were using them for, they were really meant to be, they were developed specifically for children with medical complexity as we defined up front. Like I said, if you have children who have non-complex chronic disease, or even children who are healthy who have a fair amount of social risk factors, or ACEs, adverse child experiences, they very well, it may be very appropriate to be using some of these measures for them. I would really encourage people to, think about the population they're trying to measure and whether they think it's fair to be holding people accountable for these measures for that population. The concern being that, there are some children, there are many, many children with things like asthma or ADHD or a single, chronic condition, who may not need this level of care coordination. And so their parent would, report that, no, they don't have a designated care coordinator, but that may be appropriate. So I think you really have to think about the population that you're serving and whether or not these particular measures make sense for that population. I mean, I would argue the after-visit summary measures apply to kind of everybody, but, you know, some of the messaging measures. But some of the other ones, like having, you know, an integrated shared care plan, you know, that I really think is more applicable just to the kids who have medical complexity.
Thanks. We have a related question. What proportion of the child population do meet the CMC criteria?
So I can only speak to our analyses that were done on the statewide sample in Washington State and the statewide sample in Minnesota. And in both states, it was 6% in Washington and 7% in Minnesota among their Medicaid enrollees.
Thank you.
This is David. I would just echo, we have the same number, 6%.
Okay. Valerie?
A little bit of information.
Valerie, you're using a different eligibility group, though.
Yeah, we don't have those numbers.
Yeah.
We would like to use that criteria to look at kids in our claims in the future, but right now we aren't selecting our children based on those criteria.
Thanks. So I just want to remind people, if you want to ask your question yourself, you can raise use that hand button that's at the lower right-hand corner of the participants section, and you will be put in a queue and be recognized by Sammy, right? Yeah, okay.
That is correct.
So, okay, the next is not a question, but actually a couple of leads for people saying that on plans of care that AAP has several that you can use, and Seattle Children's has some templates in their family links. So thank you for that information. And now another question. I am part of a complex care group in Massachusetts. All of our patients are complex children. Do you think this would be useful to us as we are in the process of trying to improve our quality of coordination?
I would say if you meet that threshold of being able to follow at least a population of 200 children as you're doing quality improvement work, absolutely. Okay, great. And now we have some kudos from one of your family partners, Rita, Carolyn Althouse from Family Voices, who says, great job, thank you. Thank you, Carolyn, for everything.
Okay, another question. CMHI with NIHQ, I guess, NIHQ, I'm not quite sure what these abbreviations are, has a comprehensive care plan for children with special health care needs. So here's another link to a care plan that people can use. And finally, I think, unless we get some more questions. Oh, no, we do have more questions. Can you provide your email? I don't see it in the communication.
Absolutely. So get your pens ready. It is my first name, Rita, R-I-T-A, and then a period, and then my last name hyphenated, Mangione, M-A-N-G-I-O-N-E -Smith at seattlechildrens.org.
Thank you.
You're welcome.
Okay. Now we have another suggestion from Carolyn. Rita, would it be appropriate to mention the work also being done by the center related to transitions between sites of care? And I think that's relevant. As I mentioned in my introduction, there are many, many more measures that are listed on our website as either available now or in development. But you might want to say something about these measures, Rita.
Sure. Yeah. So these were our Phase 2 measures, and Carolyn, thanks for bringing those up. She was one of the co-chairs of our working group on our transition measure development work. That work was done very similarly in methodology to what I've presented here for FECC, and resulted in both survey-based measures looking at the quality of care transitions from hospital to home and ED to home, as well as some medical records-based measures, and we, again, will have all of those tools and any publications that come from that work posted on the website as that becomes available. Those will be a little further out because, again, that is our Phase 2 work. And those measures apply not only to children with medical complexity, but any child who has a hospitalization or ED visit.
Okay. We have another, more information on care coordination, the National Center for Medical Home Implementation and the AAP are hosting the third of a three-part webinar series on care coordination. So I think you can go to the NCMHI AAP website to get that information. So Rita, another question. You, no, not Rita, but Valerie, you said that you had a quality improvement collaborative where you're using these measures. And so we're wondering, AHRQ is very involved in quality improvement. Rita, do you know of others using the measure for quality improvement? Or David, you might want to say something too.
So David, why don't you go ahead and then I can go after you.
We're hopeful, particularly for large children's hospitals that have major programs for children with medical complexity, that we'll be able to use this measure downstream for quality improvement. But to date, we don't have any experience with it.
So I can speak for our particular HICIA grants, our CMMI grant here. The way we are using the measures is we're collecting the care coordination services measures primarily, and then the ones about shared care and ED care plans. So those are the ones we selected for our evaluation. But we're also just using them internally because, and collecting them every 6 months on our population as we try to go through PDSA cycles with this new program that we're trying out with regional case managers. So we are actually using it as a way to assess improvement over time.
That's terrific, and that's really what we want to see, having these measures used, not just the measures. They're wonderful research projects and lead to more research questions, but we really want to see them being used for quality improvement. That's terrific. Well, we don't have any more questions. I would just like to thank everybody for coming to this webinar. We had a record crowd, we're told, and I'd really like to thank our panelists, Rita, Valerie, and David, for providing all of this great food for thought and leads to what folks out there might want to do next with the measures.
Thanks for that.
Thank you very much.
Thank you.
Thank you.
Bye-bye.
Yes, and the audio will be on the website in about 2 weeks. And my slides, but no other slides, sorry. Okay, because of publication issues. So thank you very much, and have a wonderful evening. Bye.
Bye.